I'm Shauni and this is my OSCE video for oxygen. Today I'm using this white oxygen cylinder. It's identified as oxygen because they either come in black or white cylinders, and it has a tag at the top saying oxygen and whether the tank is full in use or empty. And there's another part to it which is called the regulator. Inside the regulator is a Bodoc seal which ensures that no oxygen leaks out. There's 3 prongs on the regulator which match up with holes on the cylinder. So I'm just going to match those up and put the regulator on. I'm just going to twist it so it's hand tight. Okay, I'm just going to turn on my cylinder, and this one is half full. I'm just going to run through the flow rates to make sure they're all working. It goes from 0 to 25 litres per minute. So that's all working. I am going to use a high concentration mask on my patient Irfan today. I'm just going to lay my oxygen cylinder down and get my mask ready. These masks use a flow rate of 10 to 15 litres and provide a concentration of about 90% oxygen. We use oxygen when patients are suffering from respiratory distress, TBI, shock or smoke inhalation. So I'm just going to connect it to my oxygen cylinder, turn it on to 10 litres per minute, make sure my reservoir bag is inflating, and I'm going to pop it on Irfan's face. Is that okay, Irfan?
Yep.
Okay. Just make sure it's sitting on there tight. If the reservoir bag does deflate, you can increase your flow rate to 15 litres per minute. Okay, so I'm just going to take off the mask now. Okay, turning off my flow rate, removing the tubing. And now I'm going to bleed the regulator, so I've turned off my oxygen and I'm going to put the flow rate on just to get rid of all the oxygen left. Turn it back to 0 and then undo my regulator. Just for safety reasons, when you're not using your oxygen, you lie it down just because it aids in combustion and it could explode. For bag valve mask, so I'm just going to put it all together. This is the bag itself. Attaching the filter with the patient side facing out, and also attaching the mask. On the opposite end, I'm going to attach the reservoir bag, and also going to attach my oxygen at 15 litres per minute. But just with the oxygen running in the bag filling up, you can see that there's no leaks. I'm just going to pop in my OPA before I start ventilating, so I'm just going to measure it from the corner of the mouth to the mandible and putting it in upside down and rotating it in place. I'm going to use the CE grip to hold the mask in place and make sure there's a good seal to ensure there's no leakages. I'm going to do a head tilt chin lift and just ventilate every one breath every 5 to 8 seconds, ensuring that there is chest rise. If you are getting any gastric inflation, you can also use cricoid pressure to stop that. Okay, this is the lateral suction unit. When using it, you want your patient to be in the lateral recovery position. Starting off, I'm just going to test the suction unit, which should be done at the beginning of each of your shifts. When you're turning it on, you want it to reach about 300 to 500 millimeters of mercury. So I'm just going to do that now and include the pipe. But while it's still turned on, I'm also going to check the pressure coming through the catheter by blocking the hole and making sure that the suction is working. If there's no pressure coming through the suction unit, you can troubleshoot by checking all the tubes are intact and the battery is fully charged. When using it on your patient, you only go as far into the oropharynx as you can see. You only suction on the way out using circular motions for 10 seconds at a maximum. Just entering it in and suctioning on the way out. Complications from using the suction unit are induced gagging and vomiting, which can lead to aspiration, bradycardia from vagal nerve stimulation, laryngospasms and soft tissue trauma, which is why you cannot use the rigid catheter in a moving vehicle. There's other catheters used for that. This is an oropharyngeal airway, or an OPA. It maintains the patient's airway by preventing the tongue from falling back. You can also do a head tilt chin lift as well, like so. I'm just going to place a towel under the patient's neck to maintain this position. Okay. Indications for using an OPA are patients with a GCS of less than 8. Just going to measure it by placing it at the corner of the mouth down to the mandible, inserting it facing the roof. When it gets halfway, you turn it 180 degrees and push it the rest of the way in. You want to assess if the patient has accepted it. You'll know if they haven't from complications such as coughing, gagging or vomiting, and it also may worsen the airway by pushing the tongue posteriorly. This is a nasopharyngeal airway, or an NPA. Indications for using it are when you can't get an OPA in, it doesn't induce the gag reflex or vomiting, and can be inserted in a patient with a GCS higher than 8. To measure it, you put the flange at the corner of the nostril and measure down to the mandible. You lubricate it with a water-based lubricant and insert it at a 90-degree angle in the biggest nostril. If there's any resistance when inserting it, you can rotate it 180 degrees or try the other nostril, and you want to push it in until the flange reaches the nostril. Any complications from using the NPA include epistaxis and nasal polyps.
This is my OSCE video for vitals. I'm just going to start off with taking a radial pulse. So I'm just going to get consent from my patient first. Darshana, is it okay if I take your radial pulse?
That's fine.
Okay, so I'm just going to find her pulse on her left hand here. I'm also feeling to see how strong and regular it is. I'm going to count for 15 seconds and then I'll times that result by 4. So just counting now for 15 seconds. So I counted 17 beats, so Darshana's heart rate will be 68 beats per minute and her pulse felt strong and regular. Okay, moving on to the rest rate now. I'm just going to act like I'm taking the patient's pulse again. I'm just going to get her to place her hand across her chest. I'm going to count for 10 seconds and I'll times that result by 6. I'm not going to tell the patient what I'm doing just because typically they need to change their breathing rate. So I'm just doing it now for 10 seconds. Okay, so I counted 3 breaths, so timesing that by 6 is 18, so 18 is in the normal range for a rest rate for an adult. It's 12 to 20. Okay, this is my blood pressure OSCE. I am firstly going to get consent from my patient. Is it okay if I take your blood pressure, Darshana?
Yep.
Just going to put this cuff around your arm. It might get tight, but it won't hurt.
Cool.
Okay, I'm just going to remove any restrictive clothing. Okay, I'm putting the cuff on her arm. Okay, so I'm just going to feel for her brachial pulse. I'm going to pump up the cuff until I can no longer feel it, which will give me a ballpark figure for her systolic blood pressure. So I can no longer feel it around 120. I'm just going to pop my stethoscope where I could feel the brachial pulse, and that's where I'll listen for her blood pressure. Okay, I'm going to pump up the cuff once again and listen for heart sounds. Just pumping it right up to about 140, slowly releasing the stopper valve until I hear heart sounds. The first heart sounds will be the systolic blood pressure, and the point where the sound disappears will be her diastolic. Okay. So for Darshana, her blood pressure is 120 over 70. Any blood pressure with a systolic over 140 or a diastolic over 90 is classed as hypertension. This is my hemorrhage control OSCE. I'm just going to start by exposing the wound. If you need to, you can clean it with saline solution. I'm going to use the smallest possible dressing to cover the entire wound, just to ensure maximum pressure. I'm going to use a bandage to hold the dressing in place, and each time I go around with the bandage, I'm going to do a twisting motion just to add more pressure. Once that's done, if there is any leakage,
you can apply a second bandage on top of the existing one. I'm also going to check the colour, warmth, sensation and just a distal pulse, just to ensure the dressing is not too tight. If the bleeding is not controlled, you can apply a tourniquet, which needs to be applied at least 10 centimetres proximal of the wound on a single bone limb. So I'll just do that now. I'm just going to tighten the windlass until the bleeding stops or the distal pulse disappears. Once that's tight, you can record the time and attach that to the tourniquet. You want to make sure the tourniquet is visible, and if you need to, you can apply a second tourniquet. This is my fracture management OSCE, so I'm just going to start by explaining the procedure and gaining consent from my patient. So I've done that. I am just going to expose the wound on both legs. I'm going to expose both legs just so I can assess the differences. Okay, so my patient has a possible right tibia fracture. So I'm just going to use the history, so what happened, and the plus discs acronym, just to assess the likelihood of the patient having a fracture. So I'm looking for pain, loss of function, unnatural movements, any swelling, deformities, irregularities, swelling, crepitus and shock. So just before I do anything with the patient, I'm going to check the cardiovascular and neurological integrity of the limb, and I'm going to compare it with the normal leg. So I'm going to check for a pedal pulse, check on the other foot. Great, so they're both the same. I'm going to check for cap refill on each toe, which is the same, and just checking for sensation down this foot. Okay, so I'm going to ask my patient what his pain is like. So on a scale of 1 to 10, 1 being no pain at all, 10 being the worst pain that you've ever had, and my patient has said it's an 8 out of 10. So I'm going to provide some analgesia, which will be methoxyflurane, which is inhaled. So I'm just going to get my offsider to just drug check. So you can just check.
Yep.
Methoxyflurane.
Check.
So methoxyflurane is used for patients with moderate to severe pain levels, and it's self-administered, so it's totally in the control of the patient. So I'll just give it to my patient now, get them to take a couple of breaths, just to ensure that it's working before I touch the fracture at all. Contraindications for using methoxyflurane are patients with renal impairment, that have a family history of malignant hypothermia, and patients that aren't able to obey commands. So I've just got my splint here, get that all ready, and I'm just going to use triangle bandages to hold it in place. I'm just going to get my offsider to hold the limb just to support and immobilize it, and I'm just going to slide the splint in place. So we're just going to tie the bandages around it, just above and below. Can you just hold it up so I can pop this one under?
Sure.
Thank you. Okay, so just above and below, and I'm just going to do a figure 8 around the foot with this bandage. Once that's all done, I'm just going to check the cardiovascular and neurological integrity once again, just to make sure that it's not too tight. So just checking the pedal pulse again, and checking it on the other foot. Great, and those are both regular and the same. Checking the cap refill again, and just checking for sensation. To determine if a patient requires a hard collar, use the Nexus criteria or the Canadian C-spine rule. The Nexus criteria indicates patients with C-spine tenderness, which can be felt by palpating. Patients with decreased level of consciousness, altered sensation or paralysis may require a collar. In conjunction with the Nexus criteria, the Canadian C-spine rule describes high-risk population groups, for example, elderly patients, patients with comorbidities that may affect bone density, and also high-risk mechanism of injury. I'm going to explain the procedure to the patient and gain consent. Because applying the collar is a two-person job, I'm just going to get Irfan to hold the patient's head in a neutral alignment. I'm just going to measure by placing my fingers on the shoulder and measuring to the chin. It's about 4 of my fingers, so I'm just going to measure it on the collar, and it is a short collar which it already is. Just going to conform the collar just to make it easier to wrap around the patient's neck. Just going to come under the patient's neck and then wrap the collar around and secure it tightly with Velcro. Okay. Because the C-collar doesn't actually reduce that much movement, I'm just going to get Irfan to hold the patient's head until the whole body is secure. This is my defib orientation OSCE. I'm using the LifePak 12. In this pocket here we have a blood pressure cuff, 3 leads, our SpO2 probe and our end-tidal CO2, which plugs into the back. In our other pocket here we have our 12 leads and also the test load. We have GTN spray, aspirin and also a razor. In the back pocket here we have different size blood pressure cuffs, extra defib pads and extra ECG dots. Okay, just in the back we have our batteries, so under this pocket, and you can just press the buttons here to see what the charge is. Just to remove the batteries, there's a little button you can pull out, and there's also a spare battery in this pocket. Turning it on now, I'm going to turn it on and put it into manual mode because it automatically switches into AED mode. So pressing on, pressing the energy select button, and then I'll use the speed dial to enter into manual mode and just putting it at 50 joules. Okay, once I've done that, I'm going to do an operations test, so pressing options and go down to user test, and while that's in progress, I'm just going to set up my test load so I can do a test defibrillation. Cool. So I'm just going to check the date and time on my user test just to ensure that it's correct for today, 3rd of June. Cool. So I've got my test load attached. I'm just going to charge it, which will charge to 50 joules. Okay, shocking now. Cool. So you just have to be careful when delivering a shock just because it uses live energy. I'm just going to show you how to disarm a charge. So you fully charge it, and then you can press the middle of the speed dial, which will disarm it. Just down the bottom here we have our ECG printer, and you just pull it out there. Just to change the rolls, you just remove the paper, and there's a spare roll in the back. I've attached the leads and the SpO2 probe to myself. When you turn on the defib, it automatically shows the defib pedals. So I'm just going to put it to the 3-lead ECG. So just pressing lead and then going down to the 3 leads. You can also change the amplitude of each of the leads. So I'm just going to click on one of the leads, go down to size, and you can change it from 0.25 to a size 4. You can also change the QRS volume, so just going to the heart rate now, selecting the QRS volume, and you can turn it up. So that's just your heart rate. Just turn it back down again, and press home to get back to that. Once I've finished with that, I can turn it back to AED mode just by pressing Analyze. So
Connect electrode.
it's back on the AED mode, and just by turning it, pressing the on button, I can turn it off. Just before we enter, we make sure we've got our PPE on, we've got all our equipment, suction, our AED response kit, oxygen, and our radio. Checking for hazards as we walk in. I don't see any hazards. Do you see any hazards, everyone?
All clear.
Okay. Hello, ambulance. Can you open your eyes? Okay. No response from patient. Okay. So I've got all my equipment. Just going to check the patient's airway. There's nothing in the airway. I'm just going to look, listen, and feel for 10 seconds for breathing. Okay. Patient's not breathing. Irfan, can you start CPR?
Sure.
I'm just going to attach the defib. I'm going to work around you, okay? So just keep doing your compressions.
Sure.
Okay, turning that on, I'm also going to call for help. Comms AUT1, patient R49,
Analyzing heart rhythm.
R50.
Do not touch
Okay,
the patient. Shock advised.
Okay, everybody clear of the patient.
Stay clear of patient.
Okay, everybody clear?
Deliver shock now.
Shocking patient,
Raise the
everybody
shock
clear?
delivered.
Okay, back on the chest.
Pause. Start CPR.
Okay, just going to put a towel under the patient's neck. And insert my OPA. Mask ready. I also have my suction unit just in case anything occludes the airway. Okay, that's a good rate, Irfan. Keep going, thank you. You can just count down from 25.
Yep.
And I'll just do 2 initial breaths and then you can continue with your 30 compressions.
Yep. 25, 26, 27, 28, 29, 30.
Can you just let me know if you feel any chest rise?
Yep. Chest rise. And chest rise.
And back on the compressions. Okay, just connecting my oxygen. Turning it on to 15 litres. Okay, Irfan, next time the
24,
monitor
25, 26,
analyzes,
27,
we're going to
28,
rotate.
9, 30. Chest rise and chest rise.
Okay, so I'll go to my left and if you come to the head,
Sure.
and then I'll start compressions. Does anybody here know the patient? Does anybody see what happened?
No.
28, 29, 30.
Thank you.
Chest rise and chest rise. Five, 26, 27, 28, 29, 30. Chest rise. Positive chest rise.
Stop
Okay,
CPR.
coming round to the left.
Analyzing heart rhythm.
Okay.
Stay clear
Do
of
not touch
patient.
the patient.
Analyzing heart rhythm. No shock advised.
Okay,
Pause.
back into compressions.
If needed, start CPR.
25, 26, 27, 28, 29, 30. Good chest rise. Pop the windlass in the... Fuck. What do you call this? Ow, that fucking hurts, mate. No, it should be fine. Just going to insert an OPA into the patient's mouth, facing upwards, and then rotating it around. Fuck, start again, it got stuck on it. Just going to insert my OPA, measure it to the mandible, inserting, facing the roof of the mouth, and twisting. The tongue in this thing is fucked. I think so I'm just going to measure the patient's neck size from the palpating patients with decreased level of consciousness, altered sensation or paralysis may require a collar.
Holy shit.